Yes, good evening everyone. Yeah, we are going to do this one a little fast. So as I promised the other time, to look at these things here, Brugada, Verkey and Griffith criteria for diagnosing or for distinguishing between a VT and the SVT with the aberrancy. Sometimes it is very difficult to make a solid conclusion or judgment that this is a VT and not SVT, especially when there is rapid or regular word complex tachycardia. There the differentials are too many, but the most likely there are two, SVT and VT. One of the most important things to rule out SVT is age. That is one. Two is presence of structural heart disease. Yeah, and then another one, if the patient is patient of heart failure, that is structural disease, heart failure, ischemic heart disease, those ones. So if you get all that clinical information, that is one way to tell. Like if the patient is having dilated cardiomyopathy, or the patient is having had all DMI, so there we can conclude that this one is likely to be a VT. But without that one, that clinical information, still we have to tell that this is a VT. For example, like in emergency department, or when the patient comes with symptoms and complaints, and then doing an ECG, you find it's like this. There you don't need to find all that clinical information first, most especially if the patient is hemodynamically unstable. So you have to act first and then you find the information later. So there what we need is to conclude that this is SVT, because for example, if it was SVT and then you commit the patient to 1, DC shock, 2, antiarrhythmic drugs like amiodarone. So if it's SVT, the patient is receiving unnecessary shocks, or the patient is receiving unnecessary amiodarone for conversion of SVT. We don't want that. So before you take any decision, we have to find out, to confirm that this is truly VT, not SVT with aberrancy like in bundle branch blocks. So there are 3 criteria. We are going to see one today very fast, and we are going to apply on this ECG you are seeing here. You see this is a very rapid heart rate and the complex is wide. I can zoom. The complex is wide, so, and it is regular. So SVT, apart from atrial fibrillation, the rest, like if AV nodal dependent, it can be regular, or it can be sinus tachycardia with bundle branch blocks. Still it will appear regular. Also most of the VTs will appear regular. So today we are looking at Brugada criteria. The next time we shall look at Verkey, and then the last one will be Griffith. So let's first see what is Brugada criteria, and then we see how we apply it. So Brugada criteria. What is it? These are a set of ECG features that are used to differentiate between SVT with aberrancy conduction or VT. They are ECG features that you rely on to confirm that this is a VT and not SVT. So it has majorly four steps or criteria or features which are there. Number 1, it is presence of RS complex in any of chest leads. This most of them, they are looking at precordial leads. So in any of the precordial leads, we are not bothered about limb leads. Limb leads will be another criteria, but this Brugada criteria is for only precordial leads. So if RS is present or is absent, then it favors VT. Is favored. Yes. Then if RS present, then we go to step 2, which is looking at the RS duration. So RS duration we measure from, for example, if this is R and this is S, we are going to measure from the start of R wave to the nadir of S wave, and this one, it has to be more than 100 milliseconds for VT. So if it's more than 100 milliseconds, if RS is more than 100 milliseconds, then VT is likely or diagnosed. Yeah. Now next, if RS less than 100 milliseconds, then proceed to step 3. Step 3, what are we looking for? We are looking for AV dissociation. Here, AV dissociation, you have to check for at reactivity. Check for P waves. If you can see P waves and there is no relationship with the QS complex, then it's VT. If AV dissociation present, then it's VT. If absent and you can see P waves are related to, then it's SVT. But sometimes, in most cases, you may not be able to see P waves. So if P waves are missing, then AV dissociation is likely. So in the fourth, from there, if not conclusive, you go to morphology. Morphology. We have typical bundle branch block morphology. So check if not typical of bundle branch blocks, then VT likely. VT is diagnosed. So what is the diagnosis? How do you diagnose? If one of the 4 is positive, then VT is diagnosed. If one of the 4 is positive, we don't need all of them, we need only one. If one is positive, then VT, nothing to do, you just do the needful. If it's emergency department, you just have to give the shock or cardiovert medical. So we are applying these ones to our ECG, and the ECG is here. Number 1, we said we look at V1. We need the initial part of R of QS complex to be R. The initial part of the complex has to be R. So we are looking for that in all the leads. in all the leads from V1 to V6. Is it true that the first one is R? Probably. If we take this one to BQ, then RS is not there. When we look at this one, QS, QRS, 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 QRS. So these ones are QRS. QRS, QRS, QRS. Then read it to QS, predominantly negative. So this one already, by step 1, RS is absent. By step 1, RS is absent. So this one we can confirm from there that this one is a VT. So we can go to another thing. Step 2, if RS is present, if we take this one, like, okay, this one is T, and the beginning one is R here. If we take this one as T, then we say that R is the starting one. Then you have to look at RS. Yeah, you have to look at RS. We see the duration. The duration has to be more than 100. And more than 100, those are 2.5. I think it is not fulfilled. Not fulfilled here. So you have to go to AV dissociation. So AV dissociation, can we identify inert reactivity? Probably no. But if we use careful observation, this one V6, this one is likely to be P. This one is likely to be P in V6. Even in lead V5, yeah, even in V1, this one is likely to be P disturbing. Disturbing this part here, P. So P's, you can say they are not seen, fine. They are inside, they can be inside the QRS complex. So that one, it can be SVT or a VT. But SVT, why? Bundle branch blocks? No. This is not the morphology of a bundle branch block. This is, if we take this one as QRS, then QRS. QRS is not, it is not RBB, it is not LBB. So in RBB, I was telling the other time that in RBB we need RSR in V1. And then in V6 we need QRS in RBB. Now in LBB, V1 we need SRAD S waves or W pattern, and then in V6 we need M pattern. Very easy. It's not there, not the case here. So if it's not the case, this is not RBB, not LBB. So it just interval conduction delay. So still doesn't favor SVT. Even if we go to AV dissociation, we are not seeing P waves. They are within the complex. Is it SVT or AV node dependent? It may be, but with what? No bundle branch blocks. So SVT is still off. If we go to morphology is done now because we have seen it. And that's all. So we can conclude that this one was a VT. This one was a VT at a rate of 184 beats per minute. Still you have to look at the width of the complex. In the bundle branch blocks, it is conducting, but conducting a bit faster than if it conducts through the myocardium. The myocardial conduction is very slow. In case, even if it is bundle branch blocks, it is still faster than the interventricular through the myocardial cells. So QRS is 240. That is pretty wide, yeah, very wide. So this was a VT. We confirm. Otherwise, we can try other criteria. This one will look at the limb lead, the AVR, but we shall see that one next.